This is Audible Bleeding, the vascular surgery podcast. We're here to help you keep your finger on the pulse. Welcome back to another episode of Audible Bleeding. Adham Elmously here. I'm a chief resident in general surgery at Weill Cornell in New York City, and I'll be the incoming vascular fellow at the NYP bi-campus program next year. This is our second installment of a collaboration with the Journal of Vascular Surgery, where we're covering the editor's choice articles for each monthly issue. And today we're covering the September issue. We're happy to have back with us Dr. Peter Gloviczki. He's the Joe M. and Ruth Roberts Professor Emeritus of Surgery of the Vascular Surgery Division at the Mayo Clinic in Rochester. And he's the Editor-in-Chief of the Journal of Vascular Surgery, here to discuss these articles with us. Dr. Gloviczki, thank you so much for taking the time to join us today.
You are welcome, Adam. Hi. And this obviously has been a very useful and successful program of our journal to introduce some of the key articles together with a video introduction on YouTube, as well as with a visual abstract that is published each month with these articles.
Right, so the JVS have kindly made these articles free of charge for download for the month of September. So we'll have links to all these papers in our show notes, as well as a link to the YouTube video where Dr. Gloviczki summarizes the papers. So I encourage you to look at those. And today, we're actually recording a little bit early on August 15th. It's a day that I understand has some historical significance, Dr. Gloviczki.
Well, it certainly has an interesting historical significance because Bonaparte Napoleon was born on August 15, exactly 250 years ago. Besides that, both of my children were born today, so we have a huge birthday party today in our house because both of my children, my son Peter and my daughter Julia, were born on August 15th, 1 year apart.
All right, so if they're listening, happy birthday to Peter and Julia. I think we can jump in here. So the 4 editor's choice articles from this issue cover a variety of different topics, from AV fistula ligation to hybrid lower extremity revascularization. We had Dr. Lawrence on the podcast recently discussing the August issue, and he explained kind of behind the scenes of how all these papers are chosen. So I encourage the listeners to go back and listen to that. But I think we can just start. So the first paper is the editor's choice article for this month, and it's titled Using the Society of Vascular Surgery's Wi-Fi Classification to Identify Patients Most Likely to Benefit from Revascularization. This comes from Jessica Mayer and colleagues. So as we know, the Wi-Fi classification is designed to predict 1 year lower extremity amputation risk in patients with chronic limb ischemia. But in this study, they tried to identify exactly which patients within the Wi-Fi would most benefit from revascularization. And they did this by comparing the differences between the predicted lower extremity amputation risk and the observed lower extremity amputation risk for 1,600 limbs within Wi-Fi. And they did a cluster analysis and found that there were 4 distinct quartiles of patients that had different benefits to revascularization within Wi-Fi. The best benefit at a 4% amputation risk and the lowest benefit with a 50% amputation risk. And I think what's interesting about this paper is that the patients who had the most benefit from Wi-Fi tended to have moderate to severe wounds, which is not exactly within the normal construct of Wi-Fi criteria. So there's a lot to take in from this paper, but what do you think is the general take-home message from this?
There are multiple messages in this paper. When you looked at the authors, it includes Dr. Mills and Dr. Conti, as well as Dr. Schenzer. So these are 3 major players who direct us on how to treat patients with chronic limb-threatening ischemia. It was Dr. Mills who 5 years ago published and described in the Journal of Wi-Fi Classification. And if you remember, that was actually a Delphi consensus paper and really not data-driven. So any paper that subsequently was published, mostly in the Journal of Vascular Surgery, were papers that provided us additional data-driven information on how useful this classification is to predict amputation rate without treatment. And now this specific paper is with revascularization. And I think all of us should remember that this classification doesn't tell us how we should treat patients with advanced PAD, but it tells us the prognosis of the patient. And specifically, the take-home message from this paper is that indeed the classification or the Wi-Fi score can identify patients with chronic limb-threatening ischemia who get the greatest and who get the least benefit revascularization. And when it looked at the elements of the Wi-Fi score, which is, of course, the wound, ischemia, and the foot infection, they found that the wound severity is the most predictive component that predicts major amputation at 1 year after the intervention.
So you bring up a point that these clusters of Wi-Fi patients, based on their benefit of revascularization in this paper, are categorized a little bit differently from the original Wi-Fi criteria. Do you think that based on this paper, at this point, based on what we know, is there any role for having a revised Wi-Fi classification to take into account the information that we've learned from here?
Well, I have the feeling that the authors aim at decreasing the complexity of this classification. Any classification today is extremely complex, especially if you use it for research and documentation of outcome, which in many classification schemes differs from the one that you use at bedside, because there is no way that we can really, within the time constraint that we have available during a visit, that we can really categorize these patients into the complex full classification of most systems, like the Wi-Fi classification. The Wi-Fi classification, as you know, has the elements, the stages, the classes, and now this one brings us the quartiles. So I think this just tells me that there is really no complete perfect classification yet, and the authors actually are looking for criteria to best define risk and best define outcome. And I think we are getting there. I think these quartiles are very similar to the stages that were originally recommended, but indeed, as the authors in this paper noted, if you read the papers, that of the possible 64 Wi-Fi grade combinations, 15 were never ever reported in this study, for instance. So I think what the authors actually state at the end, that we need future cluster analysis comparing specific Wi-Fi presentations that are treated with and without revascularization to further define or refine the usefulness of the Wi-Fi classification. So there is more to come, but as it is obvious based on the most recently published global guidelines that Wi-Fi classification is the one that we should follow. So I would urge everybody not only to learn the Wi-Fi classification who deals with PAD, but specifically to read the latest international global guidelines written by the same authors on chronic limb-threatening ischemia.
And we can add those to our show notes as well for everyone's review. So my last question about this paper is that in the worst cluster of patients in this cluster analysis, over 50% of them required lower extremity amputations at 1 year, despite being revascularized. Do you think in a vascular surgery practice, there's a role for primary amputation and foregoing revascularization in patients in this group?
Absolutely, there is a role for primary amputation, but you should just not forget that we are physicians with clinical experience, and at any time when you use evidence-based guidelines or recommended classifications, You should look at the patient's preferences, and you should look at your own expertise, experience, and what you can recommend. So, any decision should be based on evidence, patient preference, physician experience, and it should be a combination of this coupled with the cost effectiveness. So it just tells me that, yes, there is a high risk of primary amputation. We should consider primary amputation, and it should be a mutual decision between the treating physician and the patient, whether you proceed with just another attempt because the patient is desperate to try to save the leg, or the patient understands that, the chances are not very good. And when you add your own experience and expertise, and you together should make the best decision of whether you proceed with revascularization or amputation.
Right. It's certainly a complex issue, but the paper, I think it's important to note, is the first one that not only uses the Wi-Fi for prognostication, but maybe potentially we can start to use it to guide our management. So the second article that we're going to discuss is the CME article for this month, and it's titled "Practice Patterns in AV Fistula Ligation Among Kidney Transplant Recipients in the United States Renal Data Systems." This comes from Caitlin Hicks and colleagues from Baltimore. This is a retrospective review of about 17,000 patients that are post-kidney transplant. And what this study showed was that only less than 5% of patients actually ended up getting their AV fistula ligated. The most common reason for ligation was steal phenomenon at over 70%, followed by access site complications at about 2%. The important thing also to note from the study was that there was no association between ligating the fistula and any important endpoints like allograft function or mortality. I think the conclusion is that AV fistula ligation can likely be reserved for allograft complications and doesn't have to be done primarily. What made you pick this article, Dr. Gloviczki? Is that the sense that you get from this study?
Well, this is an extremely important, interesting article of a highly controversial subject, whether we should tie off an arteriovenous fistula after a successful kidney transplant. All of us have the idea and the prediction that if you keep an arteriovenous fistula in these frequently high-risk patients with congestive heart failure, advanced age diabetes, functioning for a long time, you are going to further aggravate the patient's cardiac condition, and it will eventually result in increased mortality. So one of the reasons we picked this paper, number one, because it is a comprehensive paper of the United States population. When I look at the paper, I always want to know, is this conclusion based on 25 patients, 50 patients, or 16,000 patients? So that alone guides me about the importance of the study. And then you actually look at the data and see if the conclusion that comes out from this paper, does it differ from something that's already out in the literature, that there is indeed some evidence that there are more cardiac complications in patients, or there is evidence that there is more deterioration of the functioning kidney. So it is controversial. I was surprised to find that really only 4.6% of these patients underwent access ligation. That to me is a surprising numbers, and if you read the paper carefully, you find centers where the ligation percent was 0. So in general, it is really not done frequently. The paper is useful in a sense that it tells us, number one, that there is no obvious systemic benefit, certainly no benefit on mortality, and there is no deleterious effect on allograft failure. It also tells us that if there are local problems, and we're talking about Still syndrome, which means symptoms of hand ischemia, or there is arteriovenous access infection or aneurysms. These are the real reasons to intervene. It's interesting to read a couple of letters to the editor that will come out in the November issue, Adam, about this paper, because there were authors, specifically one group from Charleston. The first author of the letter is Dr. Solomon, who actually brings up this issue that indeed there is evidence out there that ligation improves cardiac function and maybe even prevents deterioration of kidney function. And so it's just an interesting takeaway message that when you read the journal, it's interesting to read the letters to the editors, because sometimes there is interesting debate about the conclusion of the paper, like this is going to be between Dr. Hicks and Dr. Solomon.
Yeah, I'm curious to read these letters, because in my reading on sort of the cardiac output augmentation that happens with AV fistula creation or ligation, it actually does seem like a relatively controversial topic, and I'm not sure that there's any strong data to suggest either way, but this study of at least 17,000 patients doesn't suggest that there's any significant cardiac output augmentation with fistula ligation. Do you think that there's anything specifically that we as vascular surgeons should be looking for when we're consulted on a patient who required fistula ligation? Like, should we be looking at the risk of rejection, the risk of anesthesia? Is there anything you think about other than cardiac output augmentation?
Coming back to the paper of Hicks, they didn't specifically look at cardiac function. So they looked at overall mortality. So again, the question is still unanswered whether cardiac function improves or not. My feeling is that indeed cardiac function improves, but in this large population, it did not have an effect on mortality. So when I see a patient like this, I specifically look at the local complications, if there is any reason of ligating or oversewing the fistula because of infection, aneurysm, or ischemia caused by Steele syndrome. And if there is none, then I still consult with the cardiologist to find out if there is a potential cardiac reason to take down the fistula.
I think that's a nice review of that paper. The next paper is called Hybrid Surgery for Bilateral Lower Extremity Inflow Revascularization by Sheree and colleagues. So this is a study that uses the NSQIP database. It's a retrospective study, and it looked at specifically perioperative outcomes at 30 days of patients undergoing two types of revascularization, either aorta-bifem bypass or hybrid revascularization, meaning an iliac stent with a fem-fem bypass. And they use propensity matching to control for differences in baseline characteristics between both groups. What they found was that hybrid surgery had more favorable perioperative outcomes compared to aorta-bifem bypass. Patients had less pulmonary and cardiac complications, less overall morbidity. They also had shorter procedure times and shorter hospitalizations. I think that the main question that comes up to me is this paper clearly it's looking at perioperative outcomes for this procedure. Do you think if longer term data were available, what do you think the rate of important endpoints that we always look at, like endoleaks, thrombosis, reintervention, would be when comparing these two procedure types?
Well, you bring up, Adam, an excellent point that these are 30-day data. And anytime when we look at large registries, we should look whether it is a NSQIP registry, whether it is a VQI registry, because it tells us about follow-up. It tells us the sample size and how the patients for the study were collected. And it also warns us not to make major conclusions from a study that only has a 30-day follow-up. It is important that in the perioperative period, hybrid surgery, which makes sense, is less morbid, less invasive, has a lower rate of complications and a shorter hospitalization. I think that is true, and that is the take-home message that it has favorable outcome compared to aortobiofemoral bypass. On the other hand, it really doesn't tell us whether it is a better procedure in the long run. The number of aortobiofemoral bypasses have significantly decreased in the last 2 decades, I would say, certainly in the last decade. And very seldom do we do aortobiofemoral bypass these days, because most of the time we can do an endovascular procedure to create inflow. And if we have to do a femoral bypass, we do that to revascularize both lower extremities. So again, I would be cautious about the take-home message of this and the conclusion, and focus on the perioperative period, which is an important conclusion that indeed within 30 days, hybrid surgery is as good as aortobiofemoral bypass. But you are right, we need longer-term data, 1 year minimum, but I think in any lower extremity revascularization, we really are assessing outcomes like in the PAD guidelines at 2 years minimum. So we need 2 to 5 year data to assess long-term benefit of these revascularizations.
Yeah, I think it is a helpful paper when just thinking about the 30-day period. And certainly the next step, I think, is looking at longer-term data. That's the issue with the NISCRIP database. But fortunately, there's other databases that can link inpatient and outpatient stays, things like the Sparks database, other things like that, where we can follow patients long-term. And I think that would be a good study to do next if anyone has some free time on their hands. My next question is a general question. It seems like, at least in surgical literature recently, propensity matching is sort of hot, especially in large data sets. And I think it seems like journals like to publish propensity matched studies that use propensity matching for risk adjustment. I think it's definitely a very powerful tool, but also potentially has the ability to sort of manipulate data sets in ways that can significantly change conclusions. Do you have any thoughts on propensity matching in general as a statistical tool, especially as the editor-in-chief of an important journal like JVS?
Well, we are desperately looking for propensity score matching in observational retrospective studies when 2 patient groups are compared and outcome is assessed. I think it gives a real strength to the retrospective observational studies. That's the reason why this statistical method was invented. It does not have the power of a prospective randomized studies, where really the treatment is randomly assigned and the covariates don't have an effect on outcome. I think that the primary purpose of the propensity scoring is that in these retrospective groups, the covariates that affect outcome are different, because obviously the treatment was not randomly assigned in the groups that are compared. So with the help of propensity scoring, you can match groups in an observational study and compare outcome that provides a much better assessment than in a observational study where one group with completely different covariate is compared to another group, because covariates and different clinical factors can have a major effect and outcome, and you may result to a false conclusion if you don't use propensity scoring.
Unfortunately, we only have one more paper to discuss. This is the 4th and final paper of the editor's choice for the September issue of the Journal of Vascular Surgery. And it's called Multidisciplinary Clinics Reduce Treatment Costs and Improve Patient Outcomes in Diabetic Foot Disease. And this comes from Auckland, New Zealand. In this paper, the authors studied 2 distinct phases of care in their experience. One before the introduction of a multidisciplinary foot care clinic, and one after the introduction of a multidisciplinary clinic, and they compared outcomes in a retrospective review. This foot clinic was composed of a surgeon, a registrar, an endocrinologist, a podiatrist, a diabetic foot neurospecialist, and an orthotist. And what they found was that there was a significant reduction in hospital admissions, less amputations, less mortality, less costs, overall better when there's a multidisciplinary foot team. So I think the importance of multidisciplinary care is not novel by any means. I think it's just difficult to coordinate. But this paper highlights its benefits, especially when it comes to something complex like a diabetic foot. How do you actually go about providing multidisciplinary care in this day and age?
We frequently deal with complex diseases where certainly medical, endovascular, and surgical care is required. And there is not a single specialty really who is completely qualified to take care of patients with complex diabetic foot syndrome. This is a very important paper because it brings up the importance of multidisciplinary collaboration in one of the very important area where vascular surgeons are major players. The collaboration with other specialties is very important, and it also emphasizes the importance to have a defined multidisciplinary diabetic foot clinic. This paper comes from New Zealand. And in this hospital, they had well-documented data of outcome and cost before establishment of a multidisciplinary diabetic foot clinic and after. And the study actually showed, as you said, that there were significantly fewer major amputations. Interesting enough, there were more frequent minor amputations, which also tells you that the minor amputation actually is done with improved surgical care and attention to protect and the limb and avoid major amputation. But anyhow, the center resulted in a lower mortality rate, and they also showed that it reduced total costs. So it is worth to read the global guidelines about the importance of diabetes and chronic limb-threatening ischemia, and also about the importance, the currently unsolved problem of multidisciplinary diabetic foot care centers. The guidelines actually define 3 different wound care centers, a basic, an intermediate, and what they call a center of excellence. And I think that there should be, similar to vein clinic credentialing, there should be a credentialing and a continuous multidisciplinary work, likely international, on how to credential and how to run these centers of excellence. But it's clear that multiple specialties, as many as 10 to 12 specialties and subspecialties, could be involved potentially in a tertiary care center of excellence to treat these patients and to provide follow-up care.
You sort of alluded to my next question with your answer about credentialing, but obviously this paper, and we know that in general multidisciplinary care is probably helpful and more experience is better. Do you think that diabetic foot care, as complicated as it is, should be centralized to high-volume centers that are also multidisciplinary in the same way that other technically challenging operations are, like open aortas and AVRs and Whipples?
Well, I think if you talk about center of excellence, I would think this should be done in tertiary referral centers. On the other hand, you can have a basic model of wound care in a general practitioner's office or a small community hospital. You can have an intermediate model of care in a regional hospital or at a multidisciplinary clinic. But honestly, if you are looking for high quality work or complex problems, you need a center of excellence of a large teaching hospital or tertiary referral centers, because there are so many essential skills that are needed to heal wounds and prevent amputations of these frequently diabetic patients.
Well, I think that wraps up our discussion on these papers, Dr. Gloviczki. It was a pleasure discussing these articles and kind of putting them into clinical context. I think a lot of them have a lot of potential to be practice changing. Some of them will inspire further work. But it was a great discussion, and I want to thank you for joining us on the podcast.
Thank you very much, Adam. And I think I echo Dr. Lawrence's thought as well, that we are actually very excited about this collaboration of podcast by Audible Bleeding and the Journal of Vascular Surgery, because it clearly increases the audience of the essential educational information that we would like to distribute to all vascular specialists, surgeons, trainees, and allied health persons. So I hope that this is something that's going to be successful. You find a good audience and a good response to these podcasts, and we are looking forward to working with you on this in the future.
Thanks very much, Dr. Gloviczki. Again, it was a pleasure, and then I guess we'll be back with one of these collaborations once more to discuss the upcoming October issue. Thanks very much.
Thank you, Adam.
We are Audible Bleeding, the vascular surgery podcast. We'd like to make our listeners aware that there are still a few spots left to register for the Big Apple Boot Camp in New York City, New York on September 19th to the 21st. This is a 2-day skills course intended for first-year vascular fellows or third or fourth-year integrated residents. For more information on how to register and who to contact for more information, click the link in our show.